I'm delighted to be here today. I feel just a little bit of an outlier because I'm a doctor. But let me just go back to one of the quotes in the opening video. Specialist nurses are the best. And I firmly believe that. I believe that you're actually better than doctors. I think you're more useful than doctors. I think you have a broader experience than doctors. And I think patients would want to see you rather than seeing doctors. So I've just written myself out of a job. But I do truly believe in the value of specialist nurses. So we're going to talk about multidisciplinary teams. We're going to talk about management of patients with multimorbidities. Thank you very much for inviting me here. It's lovely to join you all and to meet some old friends who I worked with a few years ago. And Pat from Birmingham and I were just talking about, what we tried to do many years ago in Birmingham that didn't work at the time, trying to bring specialists together to manage patients. So I'm a nephrologist. I actually trained in Birmingham, and I've been working in various different places, and I've ended up in London. But throughout my career, I've been increasingly focused on early prevention of kidney disease. And I would put it to you that a patient reaching dialysis is a failure of medical management of chronic kidney disease. And that if we're going to think forward and think ahead, we need to prevent patients getting onto dialysis by detecting their kidney disease early and by treating their kidney disease early. That means we need to work with colleagues in primary care. In fact, it means we need to get out of our hospitals and get into primary care to help our colleagues, first of all, detect kidney disease and then manage kidney disease. And we now have some new drugs that help us slow the deterioration in kidney function. So I think we need to rethink how we do things. And I think COVID, as you're all aware, has provided a stimulus for us to think about how we deliver healthcare. And I believe we should be delivering more of our specialist care in the community. So I'm talking kidneys, but actually kidney patients have heart failure and diabetes. And we're going to talk about that during the talk. So nephrologists have been talking about the cardio-renal syndrome now for many years. And this dates back to 2010, Pierre Ronco, who kind of made this all popular. But we've recognized in kidney disease for over 20 years now that actually the bigger problem with kidney failure is the heart. And it's actually heart disease that prematurely terminates the life of many patients with chronic kidney disease. And so we started to talk about the cardio-renal syndrome. And it's logical in a way. If you can't let the fluid out of your bloodstream, you're going to increase the pressure in your cardiovascular system and you're going to stress your heart. And likewise, if the heart isn't working and the heart isn't pumping, you're not going to perfuse your kidneys and your kidneys are going to fail. And so you see a lot of kidney dysfunction in heart failure clinics. You see a lot of heart failure in chronic kidney disease clinics. And we look at it slightly differently. And actually, if you think about it, the same factors, the same underlying causes are likely to contribute to both heart failure and kidney failure. And we've got in there diabetes, metabolic syndrome, hypertension. These diseases, these problems contribute both to heart and kidney damage. So it's not surprising that heart and kidney damage go together. Now, if you take our patients that we manage with chronic kidney disease and you follow them up over time, so here's years on the bottom, this is probability of dying, you'll see that the majority of patients die rather than reach dialysis. So these are the patients who end up on dialysis. These are the patients who die. There's a much broader proportion of patients who die over a 5-year follow-up with a diagnosis of chronic kidney disease than actually end up on a dialysis machine. And actually, a lot of these deaths are cardiovascular deaths. And so if we're going to manage patients with chronic kidney disease properly and optimally, we need to think about the other factors that are leading to these deaths. And as I say, much of this is cardiovascular death. This is my sort of timeline of diabetes. So I'm not a diabetologist. This is a little bit simplistic. But the point I want to make is that diabetes actually ends up with end organ damage. So this is time. This is the lifetime risk, or this is the risk on the y-axis. Here's the patient exposed early to risk factors like smoking and hypertension and obesity. Here's the diagnosis made. So you've got diabetes here diagnosed, but what happens to these patients is that they develop complications. And they develop heart failure and kidney failure over time. And eventually, they succumb to cardio or renal disease. So if we're going to manage diabetes patients appropriately, we've got to think about what's going to shorten their lives. And this is cardio-renal disease. And we've got to think early on about managing the risk of cardio-renal disease. And we've got drugs that reduce this risk. We have ACE inhibitors. We have angiotensin receptor blockers. We have now SGLT2 inhibitors and mineralocorticoid receptor antagonists. So there's a lot we can do here to prevent these problems or delay these problems. Cardio-renal syndrome has been around for some time, but we've now, I think many of us have now added in the metabolic component. And these are various iterations that I found on the internet of the cardio-renal-metabolic cluster. And I think some of these are promotional, some of these are from pharma companies, but I think people are beginning to get this now. It's heart failure. It's kidney failure, and it's diabetes, and they go together, and they go together in the same patients. So you've all got that, I know, and you all have this broader approach. So let's focus on a patient, and this is the sort of patient who we would see in our clinic. And I say we, I work in the community with Joe and Sarah, who are here in the audience. We have a community clinic at St Pancras Hospital in North London, and we see many of these patients referred in from primary care. This is the patient you may see. He's a 67-year-old man. He's had his type 2 diabetes for 10 years, and he's already had a myocardial infarction. And he comes up breathless. He's breathless on exercise. He can't make it to the bus. He huffs and puffs when he comes up the stairs. He's in trouble with his breathing. His blood pressure is too high. We'd all agree on that. His hemoglobin is a bit droopy. It's going down. His diabetes, to my mind, is not adequately controlled. We look towards something below 65 or 60 in kidney patients. His eGFR, his kidney percentage, if you like, is 35 mils per minute, should be greater than 90. He's lost 2/3 of his kidney function. Worse than that, it was 43 mil per minute 6 months ago. So there's been a sharp decline in his kidney function in the last year. Now, this is a bit that gets missed out, the urinary albumin to creatinine ratio, and you all know this. Nephrologists are obsessed with wee. That's what we do. We are obsessed with what comes out in the wee. That's what we do. And whilst you, most of the time, try and get your urine into the toilet, as was mentioned at the beginning, sometimes we want patients to actually collect the urine and do something with it in the laboratory. And so we are obsessed with collecting urine and getting the urinary albumin to creatinine ratio, ACR. The units are milligram per millimole in the UK. This is milligram of albumin per millimole of creatinine. We are correcting the protein for the concentration of the urine. Albumin, creatinine corrects for the concentration of the urine. And when we stage our kidney disease, and we'll come on to this in a minute, we have a G stage, which is the GFR, and we have an A stage, which is the albuminuria. Why is this so important? Because the patients who we put into the clinical trials were stratified according to not only their GFR, but also to their level of albuminuria. And we know that certain drugs, particularly SGLT2 inhibitors, are effective in those patients with albuminuria. We also know these patients are at greater risk of all the outcomes I've talked about. More albumin in the urine, the greater the risk of cardiovascular disease, of heart failure, of progression to end-stage kidney disease. So to properly stratify these patients, we need both the G and the A. This patient has had an MI. He's got heart failure with reduced ejection fraction, or hFrEF. And whilst nephrologists find it very difficult to get echoes done because we don't have access to the echo service in the same way as the cardiologists, we do recognize the importance of understanding the ejection fraction because that dictates the therapy. And we're all aware that there's many medications proven to work in HFrEF that aren't so effective or don't work in HF with preserved ejection fraction. This patient's on metformin, gliclazide, atorvastatin, indapamide. He was on enalapril, but because his eGFR has dropped, his GP has stopped his enalapril because the GP has read that ACE inhibitors are nephrotoxic. And that's a problem I come across increasingly now. In fact, one of my medical students said to me yesterday, ACE inhibitors are nephrotoxic. ACE inhibitors are not nephrotoxic. ACE inhibitors preserve and protect kidney function in the long term. The problem is that they acutely drop the eGFR when you start them, and they're on the sick day medicines list. So they've got a bad name. ACE inhibitors preserve and protect kidney function in the long term in clinical trials, many clinical trials, overwhelming evidence. They are not nephrotoxic, and we've got to dispel that from general practice. But they might be on the list of drugs you want to stop when your patient gets dehydrated and comes in sick. Okay, here's the nerdy nephrology classification system for chronic kidney disease. Here's the G stage, here's the A stage. This is albuminuria, 3 and 30 are the cutoffs. GFR of greater than 60, no albuminuria, no CKD. GFR of greater than 60 with albuminuria. If this is persistent albuminuria, you can make the diagnosis of chronic kidney disease on the basis of the albuminuria. If your eGFR is less than 60, you don't need the albuminuria to make the diagnosis of chronic kidney disease, but your albuminuria does give you the staging, and you see here the risk increasing with the increasing level of eGFR. Red, high risk, we're going from medium to high risk in stage G3A chronic kidney disease as we go to higher levels of albuminuria. These are the patients we need to see. These are the patients who perhaps could be managed in primary care. Albuminuria stratifies for risk. We need both the GFR and the UACR. So that's a bit of a nephrology viewpoint. Our patient is here, stage G3BA3. He had an eGFR between 30 and 44, and he's got a high level of albumin in his urine. He's in trouble. And in fact, to work out how much trouble he is in, we now use this kidney failure risk equation, which is recommended by NICE. This is online. You can get it on your phone. You plug in the patient's age, 67, his gender, his GFR, and his UACR in the correct units. You click submit, and you get his 2-year and his 5-year risk of ending up needing dialysis for kidney failure. Okay? His 5-year risk is 12%. He's in trouble. NICE say refer to secondary care if the 5-year risk is greater than 5%. So we're finding this tool really useful when we're talking to primary care to explain why we want to see patients in our secondary care clinics and why we don't need to see patients in our secondary care clinics. Okay, so let's just go back and look at how we view this patient. I'm going to view him from the nephrology viewpoint. And this is, I haven't said nephrologist's viewpoint because I believe in the multidisciplinary approach to patient management. This is how the nephrology service sees this man. We worry about his blood pressure. We worry about his declining kidney function. We worry about his albuminuria because that puts him at high risk. And we want him to be on enalapril, which has been stopped by the GP. And we'd like to get him back on his enalapril. We're also worried about his cardiovascular risk, and we realize he's got heart failure. This is perhaps the diabetology view on this patient from the diabetology clinic. His hemoglobin A1C is not well controlled. He's on metformin. His GFR is falling, and we know we're meant to stop metformin when GFRs get below 30. And he's on gliclazide, which is actually retained in patients with advanced chronic kidney disease. And we see patients go hypoglycemic on gliclazide as their eGFR drops because they're retaining the drug and it's working better. So the diabetologist wants to think about the drugs this patient's on, the oral hypoglycemics, and there's some obvious alternatives here. And then there's the cardiology viewpoint on this man. He's had a myocardial infarction 2 years ago. He's got reduced ejection fraction, heart failure. He didn't get coronary angiography. He's on a statin. And I think that cardiologists would want him on enalapril because ACE inhibitors are one of the proven treatments for heart failure with reduced ejection fraction. So one patient, multimorbidity, different views from different teams. Actually, we're all probably trying to do the same thing. We want to give this man lifestyle advice. I think we want to put him on aspirin as secondary prevention. We want to get him back on his ACE. We want to get him on a loop diuretic for his fluid retention. Bisoprolol or beta blockers are proven drugs in heart failure with reduced ejection fraction, and I see no reason why this man shouldn't be on bisoprolol. The cardiologist may also want him on the sacubitril/valsartan combination, perhaps instead of enalapril. I think all three specialists, nephrologists, diabetologists, and cardiologists would want this man on dapagliflozin for heart failure, for diabetes control, and to protect his residual kidney function. And we need some serious diabetes management here to control his HbA1c. So we want to get this man on the evidence-based drugs. Who's going to do this, and how is this going to happen? And this is, to me, where it all gets a bit muddled. So this is our traditional pathway. The patient visits the nephrology clinic. He gets some blood tests done. Whoever sees him in the nephrology clinic, who may be a nurse specialist, maybe a doctor, writes a letter to the GP with some suggestions in. The patient then visits the cardiology clinic. He has perhaps a repeat echo. He has some more blood tests. The blood tests go into the letter to the GP, with the GP getting advice from the cardiologist. And then he goes to the diabetologist in a separate clinic. He gets a third set of blood tests done, even though he's just had 2 sets of blood tests done quite recently. The blood test results are fed to the GP in a letter which provides advice on patient management. So this can go wrong, and I'll give you an example of where I've seen this go wrong. Patient sees the nephrologist, please restart the ACE inhibitor and start an SGLT2 inhibitor for kidney protection. Sees the cardiologist, the ACE inhibitor has been restarted by the GP, but now the potassium's gone up. And when you put a patient on an ACE inhibitor and an SGLT2 inhibitor, they drop their eGFR. That doesn't mean they've got acute kidney injury. It's how the drugs work. They depressurize the kidney function reduces for a little while. That's protective in the longer term. I'll say that again. These drugs reduce the pressure in the kidney. They drop the eGFR. That is not acute kidney injury. That is showing you that the drug is doing its job in the kidney. It's reduced the pressure in the glomerulus. The glomerular filtration rate has gone down. In the long term, that glomerulus is depressurized and will work for longer without getting damaged. So the cardiologist says, the potassium's gone up, the eGFR's dropped, please stop the ACE inhibitor that the stupid nephrologist started. Then the patient goes to the diabetologist who says, stupid doctors, they put this patient on an SGLT2 inhibitor to control their diabetes. SGLT2 inhibitors don't work when your eGFR is less than 45. They don't reduce your blood sugar. And of course, we're not using the SGLT2 inhibitor for blood sugar control. We're using it for heart and kidney protection. So the poor GP doesn't know what to do. He's got all these opinions from all these different doctors. He's got conflicting opinions from the nephrologist and cardiologist and the diabetologist. And this is a disaster. So let's just think about what we learned during COVID and how we could get how we could make this better. So these are things that I learned. I learned that patients could actually often cope without regular reviews. And some of the patients we were bringing up every 2 weeks for blood tests probably didn't need to come up every 2 weeks for blood tests. I'm exaggerating, but you know what I mean. Actually, we could possibly let some patients go a little bit longer. We could do phone call reviews, but you can't get blood on a telephone call. And nephrologists need blood and urine. But you can get blood tests done in different places. And taking my kids to school in the morning, I realized that a phlebotomy service had set up in the high street where I walk every day with the children, and that actually there are other ways of getting blood tests done. You can send a van around the community with a phlebotomist in the back and a load of syringes and needles and get the patients bled, even outside the van if you're worried about COVID. And one blood test can actually go a long way. If you order the right things when you order your blood test, the diabetologist is happy, got the HbA1c. The cardiologist is happy because you've got the N-terminal proBNP. And the nephrologist is happy because you've got the eGFR and the UACR, as long as you've got the urine as well in the back of your van. So you have to think of ways, we have to think of ways of doing blood tests better. And actually, I found, and this isn't true for all patients, particularly the underserved communities, but certainly a lot of patients we looked after actually found better ways to manage their health through the pandemic. So let's redesign this traditional pathway. And this is a proposal that the patient gets a blood test done and a urine test done. Doesn't matter where, doesn't matter who does it, but the results are made available to everybody, to the cardiologist, the nephrologist, the diabetologist, and the GP. So everybody has that blood test, and everybody has the results of that blood test. You could then formulate a plan involving the 3 specialties in perhaps a multidisciplinary setting, or you could get the consultants together. That won't happen. That will not. Let's not dream here. You will not get the consultants together talking to each other. They are well and truly stuck in their silos, in their ivory towers, and you won't get them to interact. That's where nurses come in, and that's where specialist nurses come in, because you guys talk to each other. You can interact. You can work in a professional, interactive way. And this is where you can help come up with a management plan that you can feed to the GP in one letter, endorsed by all 3 specialists, in terms of better management of this patient. So here we go. So I've changed it from the specialist to the multidisciplinary nurse-led clinic, with the blood test results fed in, agreement on what we're going to do, plan to the GP. Patient actually might want to feed in here, but the patient ultimately goes to the GP to get whatever the therapeutic change is. Okay, we had a bit of a think about our service about 6 or 7 years ago now. We found that we were filling our clinics up with patients who simply needed a 6-monthly blood, urine test, and blood pressure check. And we recognized that actually a lot of those patients could be managed in primary care. So we actually got rid of our CKD clinics for mostly full of stage G3A patients, patients with eGFRs between 30 and 60, most of whom were well. They had a bit of blood pressure. They might have had a bit of albuminuria. Many of them were at low risk of progression to end-stage kidney disease. But because they'd seen us once, they see us forever. And we realized that was stupid. And a lot of the monitoring, I think, could be done with our primary care colleagues. Let's work with them because we know what stresses they are under and we understand their problems and their stresses. But could we do a deal with them whereby they do some of the long-term monitoring and we are more reactive in seeing the patients they're worried about? We developed diagnostic clinics for those patients who we were getting referred in who needed a diagnosis, and we developed some specialist clinics. And this is really good for research. You have a glomerulonephritis clinic, you get a clinical trial comes along for IgA nephropathy, you've got all your patients in the same clinic. We developed low clearance clinics, which are led by our specialist nurses. I work in one of those with Sarah and Joe, but I've become pretty superfluous, to be honest. They're fantastic. Get on, manage the patients. We're there to provide advice if needed. And we've also offered GPs a broader range of referral options, and this gives us better control over the patients who come into the secondary care clinic. And one option that we provided was a virtual patient review service, which I just want to talk about a little bit. So here's the filter that allows you to help the GP by providing advice, but selecting the patients who actually need the secondary care service. And that could be a young man who's come up with protein in his urine, who's got glomerular disease and needs a kidney biopsy. But you know, your 89-year-old lady who's got a slightly low eGFR, a bit of hypertension, you could probably provide advice virtually on that patient without needing to see them. And also, importantly, without burdening the GP. So this was the virtual service we developed. Doctors like myself, secondary care doctors like myself, were given access to the primary database, the GP primary care database, which in our area of Camden, of London, Camden, is EMIS Web. So secondary care consultant given access, I can look up a patient on EMIS Web who's given permission for me to do so, just as a GP can log into EMIS Web and look at that patient. So if a GP wants a patient or wants advice on a patient, I can log into the GP system and I can see all the information that the GP already has on that patient, including all the blood results, the blood pressures, letters from all the different clinics. If it's a multi-morbid patient, I can see what the cardiologist has said in their most recent letter, or the urologist has said, and so on. And so this is how I work. This is me in my office at the Royal Free Hospital. This is the GP who's asked me to review a 67-year-old patient with diabetes and a low eGFR. And I can provide virtual advice here on the GP system that goes back to the GP. I may decide that that patient needs to come in to a secondary care setting, and that could be at St Pancras where we work, and that could be to a nurse-led community clinic in the first instance. And that allows us to see the patient, to interact with the patient, to find out what the patient's expectations are, to work out whether there's any easy lifestyle changes that we can make, and then to filter the patient through to the most appropriate secondary care clinic. For many of these patients, we just provide some virtual advice. You're doing a great job. Patient perhaps should be on an SGLT2 inhibitor. If you start an SGLT2, do some bloods in 4 months. If you're worried, come back to us. We'll look at it again. And then if there's other tests that are required, we can bring the patient up for those additional tests. So we feel that this is a service that allows us to help primary care. It's reactive. For the Camden system, we generally get a response back to the GP within a week. And so the GP has some information about the patient and a management plan that we've helped to formulate. We also, through this, learn a lot about what GPs are coping with in primary care. I found that really interesting. And they are doing a great job in the monitoring and management of CKD in our part of London. There are some problems with virtual reviews of patients. We've come across that. I read something about the difficulties in detecting dementia, new onset dementia through virtual reviews. You can't get blood tests through virtual reviews. You do need to do blood tests on patients. But I think we have learnt that virtual reviews are an option for some patients in some situations. And I think we need to define roles. I think we as specialists need to be available when GPs need advice. I think GPs, in return, are willing, I hope, to monitor patients over time in a structured way. We need clear referral criteria. We've got that for kidney disease. We've got nice guidance now on referral criteria. I talked about the 5% 5-year risk of ending up on dialysis as one of those criteria. Common database. We need to use the same electronic patient record. We need every result that's been done available on that so that we can manage these patients optimally. Rapid virtual advice for primary care, easy referral, let's not make it difficult. Press a button on your system that says nephrologist, and the nephrologist gets all the information they need without you having to fill in a load of extra forms with eGFRs and UACRs and rates of deterioration. Virtual consultations, clear communication flow. Let's stop doing letters, please. Let's do emails. Let's use the electronic communications. And this is the other bit, pathway for discharge from secondary to primary care. So we need a two-way flow of patients so we don't just accumulate patients in our clinics. Okay, take-home messages. Thank you for listening to me, and it's lovely to come and join you all here. I hope I've been a little bit provocative, and I hope I've given you some food for thought. So thanks very much for listening.